Well, good afternoon, everyone. Welcome to the Technical Assistance Network for Children's Behavioral Health, Cultural, and Linguistic Competence Peer Learning Exchange. The Peer Learning Exchange is a webinar or monthly call with topics focusing on culture, health equity, and disparities in children's behavioral health. Topics are generated by you, individuals working in or being served by behavioral health organizations, and those partnering with system of care states and communities. The TA Network, as it's known, is the National Training and Technical Assistance Center for Children's Behavioral Health for the Substance Abuse and Mental Health Services Administration, otherwise known as SAMHSA. Today's webinar is entitled Kujichagulia, Effective Strategies in Addressing Trauma in African American Children, Youth, and Families, and is intended to generate discussion on the intersection of historical trauma, racial ethnic identity development, and health-seeking behaviors, and to highlight trauma-informed, culturally appropriate, community-based, and clinical strategies to address resilience and the behavioral health needs of African American children, youth, and families. My name is Linda Callejas. I'm an applied social cultural anthropologist and assistant professor in the Department of Child and Family Studies at the University of South Florida, and I'm co-director of the Cultural and Linguistic Competence team of the TA Network. I'm very pleased to introduce our speakers today. And today's discussion will be facilitated by Selena Webster Bass, who's a Jacksonville, Florida native with a master's degree in public health from the University of South Florida. Ms. Webster Bass has more than 20 years of experience in cultural competency, health equity, and community health engagement. In 2016, she launched the Voices Institute, a premier training, curriculum development, and research firm focused on multicultural consciousness, health equity, and well-being. She's a core partner of our Cultural and Linguistic Competency team and previously served with the Jacksonville System of Care Initiative as their cultural competency educator. In this role, Ms. Webster Bass trained over 4,000 professionals in cultural competency and initiated and managed various projects focused on addressing disparities and disproportionalities in local child serving systems within Jacksonville. Ms. Webster Bass will be joined today by three co-presenters, the first of which is Dr. Theopia Jackson, a Howard University, Washington, D.C. alumnus who completed her doctoral training at the Wright Institute in Berkeley, California. Currently, she serves as the program director for the Department of Humanistic and Clinical Psychology at Saybrook University in Oakland, California, and is a pediatric psychologist at UCSF Benioff Children's Hospital, Oakland, in the HEAL program. Additionally, Dr. Jackson serves as the Bay Area chapter president for the Association of Black Psychologists and as their co-director of education and training. Honoring the spiritual healing of culturally centered creativity and resiliency, Dr. Jackson espouses the African proverb, "What you help a child to love can be more important than what you help him or her to learn." Next, we'll have Dr. Gloria Morrow, a clinical psychologist of national prominence who has presented her work in various venues, including in Cape Town, South Africa. Dr. Morrow served as academician and clinical training director at University of La Verne and California State University Fullerton prior to starting GM Psychological Services in Pomona, California. She currently serves as the Director of Behavioral Health for Molina Medical Management and is well known for sharing her expertise on many topics, including depression, anxiety, marriage, and relationship issues all over this country. She's been featured in numerous publications, including Psychology Today, JET, Essence, Women's Day, and Black Enterprise, and has been interviewed on radio and has appeared as a content expert on MSNBC, NBC4, and CNN. Dr. Morrow has authored books such as Too Broken to Be Fixed, A Spiritual Guide to Inner Healing, The Things That Bind, and Deepening the Ties That Bind. Because of her commitment to the faith community, Dr. Morrow has been actively involved in helping faith leaders and mental health professionals work together to help people of faith who are suffering with mental health issues, and as a result developed a handbook entitled SAFE, Spirituality and Faith Empowered, along with a three-day training for faith leaders and mental health professionals. She's received numerous awards and commendations. And we will also have Dr. Kevin Washington, whose African name is Omwata Kairi, which means great leader. Dr. Washington is a licensed psychologist in Florida and Washington, D.C., who has taught and lectured at various colleges nationally and internationally. News One has sought his expertise out with Roland Martin, Essence Magazine, Black Entertainment Television News, Vocal Point, and many other national and international organizations. Currently, he serves as the president of the Association of Black Psychologists and is an assistant professor in the Department of Human Development and Psychoeducational Studies at Howard University. As a Fulbright Hays Scholar, he has researched the impact of socializing institutions on the healing or restructuring of post-apartheid South Africa, otherwise known as Azania. It was in South Africa where he researched Ubuntu as well as Zulu nomenclature and how such can inform mental health service delivery to people of African ancestry and others. Not only does Dr. Washington work on healing the psychospiritual wounds that are present within people as a result of cultural and historical trauma, he continues developing healing paradigms for people of African ancestry who have been impacted by persistent enslavement systemic trauma, with Black males specifically and Black families in general. This work is critical to his advancing of Ubuntu psychology and psychotherapy. And as the founder of Ubuntu Psychotherapy, he advances a culturally sensitive modality for mental health counseling and psychotherapy that is culturally inclusive and particularized concomitantly. The Ubuntu model is grounded in African spirituality, religion, and philosophy, and includes elements of Western psychology that is interpreted through an African-centered lens. Through his research and writing, he seeks to assist people to live with power, purpose, and passion. Before I turn the mic over to Selena, I just wanted to remind everyone that this presentation is being recorded. Your lines are muted right now to help eliminate background noise. But please feel free to use the chat box to type in any questions or comments during the presentation. And without further ado, I'll pass the mic on to Selena Webster-Bass.
Thank you for the introductions, Dr. Kaeyes, and welcome again to Kujichagulia, Effective Strategies for Addressing Trauma in African American Children, Youth, and Families. Today's webinar is in honor of February. I'm going to ask everyone to please mute their lines, if you could, please. Thank you. Today's webinar is in honor of February African American History Month, recognizing the many contributions that African Americans have made to the fabric of America, and also as an opportunity to address strategies to improve the quality of life of African American children, youth, and families. I am elated that we are partnering with the Association of Black Psychologists, Molina Healthcare, Children's Hospital of Oakland, and Saybrook University to discuss trauma in African American children, youth, and families. Today's session is the beginning of a series specific to behavioral health in urban communities. Next month's peer learning exchange is scheduled for March the 2nd and will address trauma in children of incarcerated parents. Our April 6th peer learning exchange will focus on the school to prison pipeline. Our goals today for this webinar are to describe the demographics, behavioral health disparities, disproportionalities, and social determinants specific to the African American population, to describe the intersection of historical trauma, racial ethnic identity development, and health-seeking behaviors. And Dr. Jackson will also introduce us to the concept of emotional emancipation circles. We will also discuss the integration of faith, spirituality, behavioral health, and promoting well-being in the African American families. And Dr. Morrow will introduce us to her SAFE curriculum. And hopefully Dr. Washington will also join us and we'll discuss community trauma and provider strategies to use with African American children, youth, and families. This peer learning exchange is entitled Kujichagulia, which is a Kwanzaa principle. Kwanzaa is a cultural holiday that is observed by African Americans December 26th through January 1st. Kwanzaa was created by Dr. Malana Karenga, an African American studies professor at UCLA following the Watts riots in the mid-60s, as a way to bring unity to African American communities. Kwanzaa has 7 core principles: the Nguzo Saba, unity, collective work and responsibility, purpose, creativity, faith. Kujichagulia is celebrated on day 2 of Kwanzaa, and in Swahili means self-determination. Notice the images here on our first slide. Typically, when we hear about the history of African Americans, that history begins with the transatlantic slavery period. But before the transatlantic slavery period, there were African kingdoms that achieved many accomplishments in the fields of medicine, art, science, and technology, even with organized governments and library systems. These images also illustrate the resilience of African American people. Having come through the Middle Passage, 3 to 4 month voyages across the Atlantic to the West Indies, people densely packed into ships where 12.5% of people died during the voyage and 2.5% died on shore before the day of sail, to the Jim Crow period, to the Civil Rights Act of 1964, to even the current period of unrest with law enforcement relations and structural inequities. African American strength and resilience should be celebrated. Kujichagulia is about African Americans not defining themselves by internalized racism or the horrific and racist acts of the past, but by understanding their equal value and worth to other groups. But Kujichagulia can also be expanded to behavioral health providers being aware of implicit biases, stereotypes, and generalizations of African Americans, how we often define youth and families using low-effort cognitive processing based on homogeneous experiences, media misrepresentations, and even our early childhood experiences. All of these things impact providers' healthcare decision-making. Kujichagulia may also be applied to organizational leaders in redefining how we design systems and deliver care in meeting the multicultural needs of African American families. The U.S. Census Bureau defines African Americans as people having origins in any of the black racial groups of Africa. According to the U.S. Census Bureau 2017 profile, America Facts for Features, there are approximately 46 million African Americans living in the United States. It is projected that by 2060, there will be approximately 74.5 million African Americans living in the United States. New York has the highest number of African Americans in the U.S. at 38 million, and the District of Columbia has the highest percentage of African Americans at 50%, followed by 38.3% of the population in Mississippi. Based on 2015 U.S. Census data, African Americans comprise about 13% of the overall U.S. population as compared to 62% of the white population, not Hispanic or Latino, 17.6% of the Hispanic Latino population, 5.6% for the Asian American population, 1.2% for the American Indian population, and 0.2% for the Native Hawaiian and other Pacific Islander populations. According to the Annie E. Casey Foundation Kids Count 2015 data for child population by race, African American children 18 years of age and younger make up 14% of the U.S. child population as compared to 52% for white children, 25% for Hispanic children, 5% for Asian Americans alone, and 4% for multiracial children, 1% for American Indian and Alaskan Native, and less than 0.5% for Native American Hawaiian children. This slide shows the changing demographics of the U.S. adolescent population and projections for 2050 by race and ethnicity. Based on U.S. Census data, immigration, and fertility trends, the proportion of adolescents who are racial and ethnic minorities is expected to rise in the future. More than half of U.S. adolescents were white in 2014 at 54%, but by 2050, that proportion is projected to drop to 40% as Hispanic and multiracial teens continue to increase and to become a larger share of the population. The percentage of African American adolescents in the U.S. population is expected to decrease from 14.1% to 13%. The next two slides will address education and poverty and economic differences among African Americans compared to the larger population. U.S. high school students overall are graduating at a higher rate than ever before, and data from the Department of Education show the same is true for minority students. Nearly every racial and ethnic subgroup has seen a growth in graduation rate that outpaces that of white students, a sign that the achievement gap is incrementally closing. Between 1995 and 2015, the percentage of 25 to 29-year-olds who had completed at least a high school diploma or its equivalent increased for those who were white from 92 to 95%. For African Americans, from 87 to 93%, and for Hispanic Latino Americans, from 57 to 77%. The graduation rates for Black and Hispanic students increased by 3.7 and 4.2 percentage points, respectively, in 2 years, compared with 2.6 percentage points for white students. While we've seen gains in high school graduation rates in the African American population, we do not see the same gains in terms of annual median household income. The median household income lags behind whites at approximately $37,000 for African Americans as compared to $56,000 for whites. In 2015, 1 in 4 African Americans lived in poverty as compared to 14.7% of the nation. Approximately 89% of the African American population had some form of health insurance in 2015. In terms of family structure, in 2016, 45.1% of families with African American households were married couples. And grandparents continue to play an important role in African American families in providing support and care for children. 1.3 million grandparents live with their own grandchildren younger than age 18. Of this 1.3 million, 42.4 of them were responsible for the children's care. Often overlooked is the functional and adaptive importance of the extended family structure and extended kin networks. When delivering behavioral health services, it's important to determine the key behavioral health decision makers in the family and to include extended family networks and wraparound teams and in the behavioral health education process. Differences by race and ethnicity in access to behavioral health care and health outcomes are widely known. Members of racial and ethnic minority groups in general have less access to behavioral health care, experience more serious conditions, and have higher mortality rates than whites. In part, these behavioral health disparities are a reflection of social determinants, such as poverty, education, family stressors, where people live, and structural inequities such as mass incarceration, geographical economic disparities, and disproportionalities. The 2016 Racial and Ethnic Disparities in Mental Health Care for Children and Young Adult National Study was released last year. And the researchers examined national data from the 2006 to 2012 Medical Expenditure Panel surveys. African American and Hispanic children visit rates were about half of those of non-Hispanic whites for all types of definitions of outpatient mental health services from 2006 to 2012. African American and Hispanic children received markedly less outpatient mental health and substance abuse care than their white counterparts. These differences persisted in spite of controlling for other factors, demographic factors, mental health impairment, income, and health insurance. And researchers suggest that there are several factors that may explain the low use of mental health services. According to the study, excuse me, according to the study, factors that influence African American children and families' low use of behavioral health services were attributed to several areas. The first is the preference and reliance on informal resources of counseling, what we call the 3 F's, the reliance on family, friends, and faith. Because these are trusted sources in the African American community, relationships have been established, and there are less concerns about confidentiality. Other factors included seeking mental health services with primary care providers instead of a specialist, which supports the need for integrative care models, the integration of primary care and behavioral health services. Another factor that the researchers highlighted was the shortage of child psychologists and the shortage of minority and culturally competent providers that recognize the multicultural context of diagnosing and treating mental illness in African American communities, which sometimes creates mistrust of providers and also systems. And the other area that was mentioned in the study was stigma. For some African Americans, strength is conveyed by suffering and silence, and their cultural values about what is considered public and what is considered private. The final area that the researchers highlighted in the study were the under-provision of mental health services for African American children and the contrast with the high frequency of suspensions, expulsions, and punitive actions associated with behavioral health issues. This graphic shows Department of Education 2011-2012 data in discipline in preschool settings. Suspension of preschool Black children represent 18% of preschool enrollment, but 48% of preschool children receiving more than one out-of-school suspension. In comparison, white students represent 43% of preschool enrollment, but 26% of preschool children receiving more than one out-of-school suspension. And boys represent 79% of preschool children suspended once, and 82% of preschool children suspended multiple times, although boys represent only 54% of preschool enrollment. So we're seeing major disproportionalities in terms of high suspension expulsion rates for students of color. Black students or African American students are suspended and expelled at a rate 3 times greater than whites. On average, 5% of white students are suspended compared to 16% of African American students. Also, American Indian and Native Alaskan students are also disproportionately suspended and expelled, representing less than 1% of the student population, but 2% of out-of-school suspensions and 3% of expulsions. So as behavioral health leaders, we have to ask critical questions. Are we perpetuating systems that fail African American students with behavioral health issues, shifting them into cyclical systems that disavow them from becoming productive members of our society? Have these African American children had adverse childhood experiences? Have they experienced community trauma? We know that all behavior is an indication of an unmet need. So we must redesign family-driven, youth-guided, and culturally competent systems to address the emotional issues of African American children, not from a punitive approach, but from a clinical therapeutic approach coupled with accountability. Last year, there was a study released by the Yale Child Studies Center that examined the potential role of preschool educators and implicit bias as an underlying explanation for suspensions and expulsions in schools. Their findings demonstrated that early education staff tend to observe more closely African American students and particularly African American boys when challenging behaviors are expected. These findings are important to consider given that no behavioral challenges were even present in the videos that the individuals were watching. Eye tracking strategies were used in terms of measuring how individuals were more biased towards other groups than others. Findings also suggested that implicit biases may differ depending on teacher race. Providing family background information resulted in lowered severity ratings when teacher and child race matched, but resulted in increased severity ratings when their race did not match. There were no differences found based on recommendations regarding suspension or expulsion, except that Black teachers in general recommended longer periods of disciplinary exclusion regardless of child, gender, race. One common myth in the African American community is that African Americans don't die by suicide. And in the Journal of the American Medical Association Pediatrics, the article was entitled Suicide Trends Among Elementary School-Aged Children in the U.S. from 1993 to 2012. The findings show that suicide rates, of course, in the U.S. have historically been higher among white individuals across age groups. But in this study, when the data was stratified, rates among African American boys, the rates among African American boys had overtaken those for white boys by 2003. Between 2008 and 2012, suicide was the 9th leading cause of death among Black children and the 11th cause of death for white children. And so the rates overall did not change over these years, but the rates among Black boys, African American boys, rose from 1.78 to 3.47 per 1 million. In contrast, suicides among white boys declined from 1.96 to 1.1 per million. So, so it is a myth that suicide does not happen in African American communities, and so we need to continue to do the work of increasing mental health literacy in African American communities as well as all communities by using public education programs such as Youth Mental Health First Aid, Adult Mental Health First Aid to bring greater awareness. The next few slides will highlight results from or findings from the Youth Risk Behavior Survey. The Youth Risk Behavior Survey is administered by the Centers of Disease Control with middle and high school students across the U.S. It is self-reported data from young people. As you can see on this slide, 25% of Black youth reported almost every day for 2 or more weeks in a row so that they stopped doing some usual activities during the 12 months before the survey, as compared to 35% of Hispanics and almost 29% of whites. So in other words, the African American students felt depressed. 1 out of 4 African American students, high school students, felt depressed as compared to other students. I think we kind of jumped the slide here. I apologize. Okay, so that was the summary for that particular slide. Going to the next slide. Almost 15% of African American youth had seriously considered attempting suicide as compared to almost 19% of Hispanic students and 17% of white students. Going to the next slide. Almost 14% of African American high school students had actually made a plan about how they would attempt suicide as compared to approximately 16% of Hispanic students and 14% as similar to African Americans for white students. On to the next slide from the Youth Risk Behavior Survey. Almost 9% of African American high school students self-reported that they had attempted suicide as compared to 11% of Hispanic youth and 7% of white students. So there are many social determinants that impact health-seeking behaviors in African Americans as well as other multicultural groups. One is access to behavioral health services, the impact of poverty and the stressors that come along with toxic stress, being exposed to violence on a continual basis, neighborhood-level factors such as community violence as well as over-policing, structural inequities such as mass incarceration, family structure, adverse childhood experiences, provider bias, implicit bias, acculturation, historical trauma, community trauma, racial trauma. All of these are contributing factors to behavioral health-seeking behaviors. And so today, my co-facilitators will focus on racial trauma as a negative impact of racism and discrimination on the physical and mental health of African Americans. And they will also discuss some provider strategies that can be used in working with African American families, specifically drawing on the cultural strengths of African American families, such as communalism, faith, affirming and acknowledging the impact of race in our society, creating space for conversations for race, racial storytelling, giving youth and families space to talk about their experiences, the process of naming, validation, externalizing devaluation, counteracting devaluation, those feelings of inadequacy, internalized racism, and rechanneling the anger and rage that may come along with some of the racial trauma and community trauma that many of our youth and families experience. So with that said, I'd like to turn the webinar over to Dr. Jackson. Dr. Jackson will address the intersection of historical trauma, racial identity, and help-seeking behaviors in African American families. Thank you.
Hello, everyone. Thank you very much for taking time to be here. I'm extremely grateful and pleased to be part of this conversation and excited to see where it leads to and next steps for us all. Just very briefly here, how I want to locate my contributions to this presentation is I really want to be able to provide some theoretical and conceptual framework to help us better understand some of the behaviors and problems that may be presenting in our offices and locating them more in the social, historical, cultural, political context, and then strategically consider implications for assessment and treatment planning. My colleagues will go into more detail in terms of practical strategies and interventions. However, I will be making some suggestions about things that we can do along the way as well too. So I feel very fortunate to be among this esteemed panel. For point of background here, and particularly for this slide, I want to underscore this idea that we believe that many people of African ancestry are adversely impacted by this myth of white supremacy and black inferiority. More specifically, I would argue that this myth has impacted many groups, not just those of African ancestry. And however, our focus here is going to be on the lived experiences of those here of African Americans, but I will also use this as an interplay with this idea of African ancestry because I want to honor the fact that many African immigrants, first-generation immigrants, are inheriting a legacy of racism and oppression here that may not be familiar to them, and yet they're now having to respond within this. Many of us are aware of and familiar with the African proverb that states that it takes a village to raise a child, yet we want to argue and be curious about what happens if that village is hurting. We also know that this type of a cultural value is central for us in the sense that I am because we are and we are because I am. That for many persons of African ancestry, African Americans, we are interconnected. This poses both an opportunity and challenge. The challenge that's here is that many of our Western approaches to treatment are predicated on individual or maybe family approaches. Yet we would say that for optimal healing and sustainability and well-being, that we do need to take into consideration the full social communal world of those that we are working with. That this is more of the center for us for our strength, our resiliency, and our life force, and so therefore should help inform assessment, treatment, and intervention. So adding to our language and understanding of trauma, and I want to appreciate the work that was done by my colleague here. I think we can all agree as Americans who are on the call here, the residuals of 9/11 and also the more current acts of terrorism and the psychological impact they're having on all of us. We do not have to have been directly involved to feel the pain. Well, I submit the same logic is true for many persons who are parts of groups that have been marginalized or disenfranchised here on our shores, but today's focus is specific to those of African ancestry. That when we talk about this idea of post-traumatic stress disorder or post-traumatic stress in general, there's a challenge there because for many of us this is persistent or ongoing. It assumes that something ended, and I would argue that in many cases, in many situations, some of the racism, oppression, disenfranchisement that we began to experience in the very first times we came on American shore continues. It's just in a different format. It manifests itself differently. We also want to pay attention here to this idea of vicarious trauma, that there are different types of trauma that are being impacted, and the one can trigger the other, if you will. And we'll look more at this in a moment. And then, of course, this idea of secondary stress disorder or compassion fatigue, and that is really speaking to those of us who are in the field doing the work in the trenches, that when we're exposed to so much trauma for those that we're trying to serve, it also impacts our own well-being. So as we listen to this call and think about our own work, I really want to underscore the importance of self-care in this work and moving towards more of our own resiliency as providers. For this slide here, again, we're bringing in some more concepts that may be familiar with many on the call, but I really want to intentionally and strategically enter these concepts into the general populace and language. More specifically, one might say if a child is being presented for treatment because of acting out behaviors or difficulty staying focused, then part of the conversation some wish might be, what, if anything, do these symptoms have to do with complex trauma specific to cultural trauma, historical trauma, intergenerational, or racial? This becomes quite prevalent when we think about the study that was done on adverse childhood experiences in 1998 with Kaiser, which is referred to the ACEs study, which demonstrated with more than 17,000 predominantly white middle-class men, we showed that adverse childhood experiences such as exposure to loss and death of a loved one, divorce, things of that nature, had an impact on the quality of life. It really adversely impacted their adult development. Well, to take this further, many persons of African ancestry are embedded in urban communities that have other unique stressors with them, such as exposure to community violence, witnessing of violence, and ongoing threats. So I want to applaud the work that was done with the Philadelphia ACEs. It was headed up by the Institute for Safe Families, where they expanded upon the ACEs and began to look at some of these unique stressors within urban cities, and again with a very large population of over 17,000, predominantly African-American males and females, and they found that there was a much more significant adverse impact on overall development and outcome. So this says we have to pay attention to the interplay of different types of trauma that are being experienced with those that we're serving. We may know that a child is in recovery from sexual abuse or some other type of known abuse, but we have to also say and be aware that that recovery is impacted by other experiences of trauma that he or she may not be able to name but are exposed to. And we'll hear more about that as we continue in our talk here. So, moving along. I want to give tribute to one of our phenomenal leaders in Black psychology, Dr. Wade Nobles, who's also introducing this idea of psychic terrorism, to think about it when you're looking at trauma in the Black communities. More specifically here, what we're saying is that each time these assaults are being publicized in media, each time we hear of some experience that a Black person may be having that has implications of race and disparity, that it's sending certain messages to the psyche of other persons of African ancestry. Now again, I think it's also impacting our cultural allies, so I want to underscore that, but today's talk will focus on how it's impacting us. So there are ways in which there are many communities where parents are fearful to allow their children to go out into the public, if you will. Or I might say there could be that situation where a provider feels like an African-American mom is too strict and too demanding on her child. And I would submit it might be generated by this psychological terrorism that if I can't help my child to do right in public, he or she could fall victim to some event where they're being mistaken or not seen for their own humanity or not able to come home from going to pick up Skittles. That this is a real fear. Dr. Kenneth Hardy talks about a healthy sense of paranoia. So we have too much evidence in our black communities that there's reason to be fearful. There's reason to be somewhat distrustful of research or even of those of us who are presenting as part of the helping system because of this historical trauma and social political context we're sitting in. So what it really speaks to is that the onus is on us as providers to earn the trust of the communities in which we serve and to appreciate that even though our intentions are good, we are part of a system that has perpetuated not so good intentions, if you will, and exploitation for many communities. And we have too much evidence of, quote, good science being used in adverse ways for persons of African ancestry. So at the end of the day, how does all this affect that basic question of who am I, one's identity formation? We think of who we are as sexual beings in terms of our gender, our role in our families, but there's also this idea of ethnic identity formation. That with optimal development, one does need to have a good sense of who he or she is as a person of color, as an African American, as a black American, as an African person of African ancestry as well. So and sometimes these are both implicit and explicit messages where there's an intentionality of trying to build up and make sure that our children understand the healthy and strong and phenomenal history from whence they came that was far before our coming to these shores. However, what we want to pay attention to, I want to bring more attention to now, is this idea of internalized oppression, that our children and families are bombarded constantly with messages of negativity about who they are in their black skin, the kinkiness of their hair, the darkness of their skin compared to lighter, fair folks. There's multiple ways in which we're sending these messages to ourselves, to each other, and these are also the messages that are informing implicit bias that may be showing up in healthcare providers who have good intentions but yet are not realizing that they too are working from these myths and negative images and ideas of what's happening for our people, if you will. So I'm just raising this because, like in any sense of trying to be in recovery and reclamation, there needs to be more intention to really defining who we are and accepting responsibility for who we are and moving forward in such a way that we are actively participating in our own healing, recovery, and working with those who are serving as our support in this work. We have lots of literature that begins to speak to the reaction that trauma can have on multiple levels. These next three slides sort of brings attention to the responsibility at the individual level, the community level, and family level. However, I really want to say we want to look at them in terms of their interplay, their intersectionality, because there's diversity within groups. We may have some individuals who are presenting for treatment where the root of their challenges are more at the impact of trauma on a family level. What it's done to their family could be really impacting who they are as an individual. And then again, it may be more at the individual level. But I offer these slides for consideration, again, around this idea of assessment and treatment planning, and how these different ways in which one could be responding to trauma. Many times I'm hearing folks say, well, there's lots of community violence and black-on-black crime. I don't have the numbers in front of me. However, I want to submit that there's not a significant difference between, quote, black-on-black crime versus any other culturally specific crime, one to the other. And I'll also argue that's not really the primary focus here for me. Instead, what I will say is I do believe and wonder that a lot of the stress and violence in our communities could be the residuals of unresolved trauma, unresolved internalized oppression, where we are sort of bought into this idea that there's something, quote, wrong with us and end up operating from that particular space and time. So once again, these are things that I'm proposing that as healthcare providers, mental health providers in the general community, that we consider to see their contribution to the issues that are presenting, that we're working with. Again, looking at the social and societal levels, I think that the most recent events in our country lays groundwork for the intensity of what I'm referring to here. I would say that the Black Lives Matter movement grew out of this social societal unrest. And though it has been very painful, I do believe that it is out of chaos that clarity can emerge. It is moving through the trauma that we get to the growth and the resiliency and peace, and that is what I'm hoping that today's talk will continue to contribute to and inspire for others. So when I think about some of the most recent events in our country now, I do find it interesting that as an African-American woman, I'm struck by the fact that wherever I go, I'm finding myself in conversations that are emerging about the social political context and its implications for persons of color, particularly Black folks in this work. Yet when I'm sitting as a clinical psychologist among many of my peers, I have a lot of empathy as I hear my colleagues talk about, well, you know, I'm not sure how to bring this up in treatment, or I'm trying to follow the lead of my client. If he or she doesn't bring it up, then I don't get, or the other good intended clinician who's so much aware of the level of stress and intense in our communities that they may be pushing the conversation too soon, too quick for the particular client who's like, wait a minute, that's not related to me. So I'm just wanting to underscore again that this is impacting not only persons of African ancestry, but all of us in America, the unresolved issues of cultural, historical trauma within the Black communities. So again, moving towards our own wellness and wholeness and next steps, if you will. And as I said, my colleagues will be much more specific, but we do want to talk about realignment after trauma. And again, the term after is questionable here because it does presume that something has ended. So it really is about how do we sustain, maintain, define our own humanity, health, and wellness in the context of trauma. And what this, for me, then speaks to is that in many ways, looking at the resiliency of populations like persons of African ancestry on these shores, it positions us to understand them and their expertise as survivors and resiliency. What can be learned from the humanity of persons of Blacks who've been able to contribute to our country, to our society, in spite of this type of a context, if you will. So this leads us to think about this idea of Sankofa that is populated quite a bit in the literature, and it is an Akan language of Ghana that speaks to how we go back, take, and move forward our own reclamation, because I would submit, like with any cultural group, that we have within us, within who we are, our essence, our spirit, the capacity for self-healing and to become whole. However, we do not always have the tools to access that, to move it forward and to claim it in our work. And again, I'm hoping that today's conversation can help move some of that forward in our various ways in which we interface. So I'm thinking of this when we're trying to center African worldviews and what it means to be human and our sense of connectedness and wholeness. I want to again pay tribute to the work of Dr. Washington with regard to Ubuntu theory. Into theory, which is really prominent, and appreciating the work that's coming out of Dr. Frederick Phillips' work in Washington, D.C. Also looking at optimal theory, which was theorized by Dr. Linda James Myers. So we do have within Black psychology a number of scholars who've begun to lay the groundwork for centering culture as part of health, wholeness, and wellness. So I am employing our scholars on the call to strategically critique and access that literature and decide how it fits in your work what fits for you and what doesn't. For those professionals of African ancestry, how do we integrate this into our work and move it forward, owning this for our own? For our cultural allies, how do you also consider the work that's been done in Black psychology and contribute to this discourse and locate yourself in this part of the work as well? So again, for a visual, this speaks to the African trauma cycle that I'm sure Dr. Washington will allude to further, and placing what we mean by the Sankofa, that this needs to be very intentional in our recognizing, reclaiming, and integrating our own indigenous healing practices into our wellness, if you will. I'm reminded, again, that scholars like Dr. Nobles would say that many of us are African by nature and American by nurture, so we do need to look at the integration of these cultural practices within our Western ways of thinking about health and whole and wellness. More specifically, the next two slides illustrate from a culturally centered perspective the concepts of health and healing. Once again, they are listed literally, but they should be experienced as interactive because of the multicultural nature of our society and the globalness of our world here, there are many ways in which someone may be identifying from one particular cultural background, but are moving through this idea of concept of health and healing that's informed by different groups. So as you review these two slides, they are not exclusive. And once again, I make the assumption, deduction, request that we could be doing our own assessment of where our clients are in terms of their understanding of health and healness, and therefore it has implications for treatment planning. So once again, I'm really wanting to underscore that we want to come from a more of a strength-based place where we're honoring the resiliency of our persons of African ancestry. When I'm working with clinicians in training and I'm hearing them sort of present their cases and they're talking about the significant numbers of, quote, known trauma experiences for clients, maybe they're living in impoverished situations, they're survivors of physical and sexual abuse, they're also dealing with racial disparity in the classroom, that sometimes I can hear the hopelessness in the voices of the healthcare, mental health providers, and I'm wanting to ask you to take a deep breath and step back, and instead be able to ask yourself and also ask the client that you're working with, what has helped you to survive in spite of all of this? To honor that our people are stepping forward, and how do we lend our skill sets, our tools, our theories, our practices in support of clients and families' self-determined healing and capacity to thrive and be. And also, how do we think about this within the context of community? This again is pushing back on the general theme of individual treatment or family treatment. I'm really saying that we do need to be asking ourselves, what is the nature of the setting in which our clients and children are residing? Our children are not at risk, they're at potential and at-risk environments. If we think of it that way, then we cannot help but consider what is the role of our treatment in our theory and our conceptualization of the problem when we consider the environmental factors and how we can help in this situation. Okay, what's going on here? So again, Dr. Washington will speak more specifically to this. I wanted to highlight this particular slide because I want us to bring attention to the fact that many times we are doing some errors here. We make some assumptions about our community. There's too many times when we're talking about the absent father, and I want to argue that there are many, many Black fathers who are actively engaged in the raising of their children, and when we are positioning a particular stance that they're not there, then we are dismissing the true presence of folks. So, and if something also happens to the mind of the healthcare provider, that we somehow get comfortable with the idea that this, quote, no father, we proceed in treatment without paying much attention to that. So I'm wanting to sort of really ask us again to step back and be more intentional and say, we are the healers within this child's family. How do I partner with them? How do I learn from the family and the child where their strengths are, what's helping them to get through, and how do I use that as tools for building upon my own care in working with them. Next slide, great, there we go, okay, good. We have many evidence-based practices here in terms of, trauma-focused CBT and other approaches, so they have their value for sure. However, what I'm promoting here is a shift. How do we move away from thinking of ourselves, quote, solely as providers, and what does it mean to become a healer? And what does it mean to, as I said, to think about how do I help promote quality of life changes with those who I'm serving? How do I partner with them, follow their lead, provide my knowledge to them to help raise a certain level of consciousness so he or she can be more active in their own treatment and care? Again, this speaks to the whole idea of trauma-informed, where we talk about what's happened to you versus what's wrong with you, and understanding that many communities have a number of grassroots, small organizers who are doing some phenomenal work. I want to offer two very brief tools here. This Family Care, Community Care, and Self-Care Toolkit that was co-created by the Association of Black Psychologists and Community Healing Network was designed to be used widely by both the general populace, professionals, trying to think about how to integrate more of this into their care and practice. We have this idea of kitchen table talks, just kind of open conversations of who we are and how to understand the madness that is around us. I'm thinking about the work that was done in California State, where they're looking at the mental health issues for African Americans, and they very nicely titled their packet, we're not crazy, we're just in crazy systems. So sometimes there are systemic issues at play that places us in situations where behaviors that are problematic are really normal reactions to abnormal situations. So I really want to underscore people being able to use these tools, seeing how they fit for you. They're live, organic documents. I also wanted to underscore the work of Paul Thoreau, who's looking at effective cultural allies. He has some wonderful practical tools on his website that could be of service as well, too. And moving right along, for healthcare providers, the healthcare providers, we do, as I said, want to be able to think about the context in which our children and families are living their lives and what is our role in that treatment and how do we address some of this through the work that is going to be presented that Dr. Washington and Dr. Morrow will bring to attention here in a moment. And lastly, just to kind of highlight initiative, a collaborative again with the Association of Black Psychologists and the Community Healing Network, we've designed these emotional emancipation circles, which is a set of curricula, if you will, in the spirit of self-healing, that once we train people in the Black community, they're able to sort of run these healing circles for themselves with this idea of being designed for us, by us. And our allies are in support of this work because they really are intended for persons of African ancestry, predicated on the idea we do need to do some self-healing to help us be even stronger when we're matching with our community partners or other cultural allies. So emotional emancipation circles are intended to help heal the village that heals the child, if you will. In closing, let me just say here, too, that I'm hoping that the takeaway from this particular part of the talk is really supporting and nurturing our consumers or general families to really bring up these types of things in their conversations with their healthcare providers and mental health providers, to just kind of say, so what does all this have to do, if anything, with some of the problems I'm dealing with now? We have a lot of literature that speaks to the adverse impact of exposure to racism, both on the mind, body, and spiritual level. I'm also hoping and trusting that African American professionals on the call will continue to move their voices forward as they integrate who they are as cultural persons with their professional identities, and recognizing that we are inheriting a system sometimes that has a history of doing less than optimal work in our communities as well as doing good work. And then lastly, just really wanting to encourage our cultural allies in this work to continue to engage in this discourse, to be in the Black psychology literature. Also, for the Association of Black Psychologists, we are now doing things like trying to design more webinars to share with the general populace. We are also having pre-conference training that we're offering to the public. Our next conference is scheduled for July 18th in Houston, Texas, where we would invite folks to kind of come out, be in conversation with us to see how Black psychology can be a support in your work. And then the conference itself is from the 19th to the 23rd. So thank you again for this opportunity. I'm going to turn this over next to my colleague, Dr. Morrow, who will address the integration of behavioral health, faith, and spirituality in practice. Thank you.
Thank you, Dr. Jackson. That was just awesome and wonderful information to help us to set the tone for some of the strategies we may be using that can be helpful in our communities. I want to thank Selena Webster-Bass so much for her involvement and getting us to this space where we could have these rich, I like to call them wonderful conversations that are sometimes difficult because we are so much involved with caring for our African American families, and I'm looking forward to hearing Dr. Washington to kind of tie this all up for us. But as we look at what is useful for the African American community, one of the things we do know is that faith is very important. And so I've been doing some work around trying to help to develop a training program and curriculum to help not only providers to understand the role of faith and spirituality in the lives of African Americans and all communities, but also to help faith leaders to understand the role of mental health and to help them to begin to give permission to those who are culturally responsive in working with the African American community. So I have some slides here. I'm going to kind of go quickly because I want to get to the actual program because I think that is going to benefit you probably the most from my presentation. But we would look at some of the key terms, discussing the role of Black church in the African American community, and also kind of develop this rationale for why it's important to include spirituality in the delivery of services to African American families, and then to develop strategies so that we can provide the best care. We know historically that mental health and religion had some relationship. It wasn't very positive. Many people believe that mental illness resulted because people were possessed by the devil, and we started having an evolution of conversations about how faith and religion was detrimental to people's emotional and mental health. And so it's not so difficult to believe that some of that belief system has not transferred over to our modern day, where even today we hear people talking about the need to not include spirituality and religion because it could be something that has, negative consequences. We saw that religious experience was often labeled as psychotic, and we saw that in our DSM-3R. And this was prior to 1994, but then in 1994, a paradigm shift occurred, and we did include religious and spiritual problems in the DSM-4. We know that our academic settings continue to have some problems resolving this religion mental health dilemma because of the separation of church and state, and we saw this gain notoriety in this thinking after prayer was actually taken out of the schools. We know that now we have research evidence that spirituality and religion and faith are critical to people's recovery. We see that more in the medical field than we do any other field, but we know in mental health, many times people are not accessing those services because they don't feel as though it is responsive to their religious and spiritual perspectives. People often refer to spirituality more than they do religion as a variable that increases hope. And when we know that when we have these terms that they can also be interchanged, but we know that people who are very spiritual or see themselves as spiritual have a real need to have that included in their care. This is just some definitions of religion and spirituality, making the distinction. We know that religion refers to the rituals, the organizational structures that we have with religion. But spirituality, on the other hand, is more abstract and transcendent aspects of a belief system. And we know that sometimes it has been frequently associated with mystical experiences, intense emotions, and meaningfulness. And so it is so difficult for us because many times we don't understand how people define spirituality. But Jay Mahler, who is a consumer who kind of brought this to home for us, he says for many people with mental health issues, spirituality is key to understanding this experience. It is essential in their journey of recovery. And we see this over and over and over again, that many folks who are dealing with mental health challenges really know that it is important to have some aspect of spirituality in their care. In fact, if we're going to be culturally responsive, spirituality has to be included because spirituality is another vital aspect of culture that must be included. We also know that mental health disparities persist when providers don't fully understand and respond to the cultural world of those they serve. And so it's important for us to include spirituality because we continue to see misdiagnoses and premature termination and other cultural errors committed when we aren't really meeting the cultural needs of the people we're serving. Spiritual disconnection can lead to despair. We know that we have little research as it relates to African Americans and spirituality, and we are so grateful that we have Dr. Washington on the line, who is going to talk a lot about what's been happening with Black psychology and how we are now seeing more of that research emerge. But we do know that many people of all racial and ethnic backgrounds believe that religion and spirituality favorably impact upon their lives and that well-being, good health, and religious commitment or faith is integrally intertwined. And so we know that it is very important. We know also that spirituality is a cultural fact that has to be considered, as I said before, but we also must know that there are within-group differences. When we look at the African American community, it is not a monolithic community. So many times we think that all African Americans are Christian, and that is an error. So we have to begin to look at diverse definitions of spirituality and religion and understand what Dr. Wade Nobles would define when he said that he is promoting the idea of spiritness, which refers to the family, past and present, serving as the spirit of the life force of the family. So we can't really work with African American families without including their concept of the spirit. We see some data here, and you can look at this on your own. There's a lot of data that tells us why we have such a difficult time with including spirituality and religion. And California has done a lovely study on that, telling us that we are in trouble here because we have not been able to embrace this concept as easily as we should have. And also, there are these diverse definitions of spirituality. Sometimes provider bias can happen because of different worldviews, resulting in our failure to value and embrace diverse spiritual perspectives, because you may not believe the way I believe, so I'm not going to embrace the way you believe. And sometimes we have our own countertransference issues that emerge because of our own negative and oppressive experiences with spirituality and religion. There are many other things here that we can consider about why it is so difficult. Sometimes lack of institutional support, and sometimes we're not really familiar with our own spirituality and spiritual practices and may not see ourselves as a spiritual being. We know that there are many, many religious groups, but the three main ones are Islam, Christianity, and Judaism, but the majority of African Americans are Christian. We know that spirituality is central to the African American worldview. because of communalism, a collective identity that manifests in strong kinship ties that often reaches beyond one's biological family to an extended network of relatives and other community members. We know that the Black church was formed during slavery, and it embodies this sense of connectiveness, although there's some debate about what really happened during slavery with those churches that were often guided by white principles. But during slavery, the church not only functioned as a place of spiritual worship, but as an education center. It was a shelter for Africans who were escaping bondage and a resource for economic support. And also, we saw a lot of political organizing happening in the Black church. It was a place for liberation, and sometimes the pastors of these churches were revered as the master teacher, preacher, father, lawyer, doctor, and everything that had to do with the family. And so it brings me to a short case I wanted to share with you about the importance of including spirituality and religion. Number one, when Lena came to see me, Lena was a 14-year-old who had been having a lot of difficulties in school. She was also having some challenges at home and was smoking marijuana. And one of the reasons she finally got to see me was because she finally did some shoplifting, and it ended her in juvenile hall. And then as part of her treatment, they wanted her to be seen by an outside therapist. But her family was very opposed to her coming. There is a lot of stigma associated with mental health and mental illness. And so a lot of times Black families don't want to go outside their faith communities for help. And so finally we had to see her because it was court mandated. And it was important for me to acknowledge the role of spirituality in her family's life and ultimately in her own life, and to get to some of the trauma that was causing her to behave the way she was. It was imperative for me to even have a representative of the faith community there in the room. So it is important. And when we find positive ways to engage the African American community, we will find wonderful ways to become more self-aware, to examine positive and negative attitudes, values, beliefs, and behaviors around spirituality. As providers, we will embrace our own spirituality and be willing to have courageous conversations that are often very difficult for us to have when we're so concerned about us having some type of tool to help providers and faith leaders come together. I developed SAFE, which is a 3-day cultural competency training program, which is designed to equip mental health providers with the tools to embrace the integration of faith and behavioral health. But also, it is for faith leaders. It helps the faith community to become knowledgeable about its role in addressing the mental, physical, and social needs of its diverse community members, and also to identify and eliminate the barriers that prevent communities of faith from assessing mental health services. We also work with pastors and faith leaders to find strategies for reducing stigma, and then learning how to work with providers of care in systems of care to work with people who are in need. It's so important for us to work together. It is more important, however, for us to acknowledge that people who are hurting, who have faith as an important part of their lives, that it must be included in that process. And so I'm sorry we don't have a whole lot of time for you today, but I hope this has at least given you a glimpse as to what can happen when we work together. And I'm so honored to introduce our next speaker, who is Dr. Kevin Washington.
Thank you, Dr. Morrow, and Dr. Jackson, and Sister Dr. Selena Webster Best putting this all together. We're going to do this in a manner that can honor the process, because you've heard so much already about this entire endeavor of why it must be grounded within a cultural context, and we talk about also why it is in this time frame this month. And I ask often what's the question, why do you think Black History Month occurs within February? And the response commonly is because it is the shortest and coldest month of the entire year. And what happens is that when you understand Dr. Woodson's thought, he was trying to honor individuals who engaged in the process of liberation. So he wanted to honor the birthdays of Abraham Lincoln and Frederick Douglass. And so that's how it gets pushed there. But because we are people that's so used to being traumatized and marginalized, we automatically take the default position of simply suggesting that this is yet another way to be marginalized. Dr. Woodson was very instrumental when he suggested this idea that when you control a person's thinking, you don't worry about his actions. You don't tell him to come here, to go there. You find his place and he will stay in it. And he talks about the idea of conditioning. And so what we want to address within the next few minutes that we have together is this idea of what is the process of conditioning of a population to be able to assume the role of being marginalized or ostracized or dehumanized and begin to own that as if it is their particular lock, stock, and barrel. So we have to look at this idea of trauma. And so if you look at trauma, emotional response to a disaster, but within the African-centered context, this idea of trauma really looks at this notion of assault on essence or being or spirit. So anything that disrupts that is indeed a trauma. We think about the medical term trauma with something injury to the body, but in this case we're talking about injury to the essence of life, and that's what's happened in this whole discourse today. We know that we people typically recover more quickly from certain types of trauma, such as the acts of nature or acts of God, because they are outside of themselves, the event, and so they have no control over it. But when there are events that seem to be associated with something about their humanity, whether it becomes rape, other forms of violence and enslavement, then that type of recovery from that kind of trauma is different because it comes at a different place. It comes to an individual based on something that they cannot really get rid of. In the case of rape, one cannot get rid of their sexuality. In the context of skin color, you can't get rid of that. So it becomes very problematic for a population to have to deal with the idea of trauma, that the traumatizing experience is my being. And that's why we talk about the idea of re-traumatization or persistent traumatization, because what happens is that this trauma is ongoing because the ideology that gave rise to the causality of the trauma has not been released. And so we have to look at this within the cultural context and understand clearly how we're going to engage in the healing process. So types of trauma that I mentioned quickly are natural disasters, social, political, and collective remembering processes. And so we are in the throes of course, a cultural trauma, social, political trauma right now. The events of nature, earthquake, hurricane, and I want to pause for a moment and show you how you can actually couple this notion of a natural event with the idea of internalized or internal cultural trauma. So you had Hurricane Katrina in New Orleans, and so the natural disaster was the hurricane. The phenomenon was the flooding. The disenfranchisement of the population occurred in the context of the media by saying that when African people of African ancestry were trying to find food, they were looting. But when Europeans were going to get food, they were simply going out and finding food. Or when there was no real help given to African Americans when they were in New Orleans, or the idea also of African Americans being called refugees as opposed to Europeans being called individuals who were dislocated. So you have this disavowing of the essence of a population that has these this merging of two types of trauma. One was the physical or the environmental, and one is the social cultural one. And one can move through, of course, quickly the physical one, but the social cultural one that really causes this internal damage is the one that seems to have the long-lasting notion of injury to one, because you have to understand that the essence of being is what was attacked here. So to understand the kind of work that we're doing here, we have to understand the cosmology, axiology, ontology, and the epistemology. And I want to pause on this idea of really axiology or the values. Axiology deals with the values of a given people, and people of African ancestors typically value this idea of humanity or humanness, and spirit and spirituality is tied to that particular context of being human. If you act like you don't have spirit, then you are really not considered to be human. And so there's more that we can talk about that in the context of what I learned in South Africa. But one thing I did get from South African psychologists or counseling group, is that they talked about continuous traumatic stress that occurs to individuals in apartheid South Africa, because they noticed that there was no moment where there was some type of relief. We talk about the idea of Theophilus mentioned this earlier, Dr. Jackson talked about complex PTSD. And so we understand that complex PTSD exists because you have a continuing process of having trauma. But my question is always, what do you call that type of trauma when it is linked to the cultural phenomena of, in this case, blackness or Africanity? And so, so we know that the worldview of folks of African ancestry are tied to this idea of being collective, and that the human nature is about understanding spirit and spiritness. I'm not going to deal with those. I'm going to give a correction to this slide that says post-enslavement systemic trauma, which is kind of where we were starting the conversation, and put it back to where it is, which is persistent enslavement systemic trauma, upon a conversation with my elder Dr. Wade Nobles, and he encouraged me to think about the term. And so we use this idea of persistent enslavement systemic trauma, which suggests that there is this ongoing process that's tied to the enslavement ideology, not necessarily the experience, but the ideology that gave rise to one group being superior and inferior to another. And it's systemic in that it tends to go through everything that a population deals with, and then lastly with this idea of trauma. So we see then that there's psychological devastation, spiritual disruption, emotional destabilization, economic disinheritance, and political disenfranchisement. And I think that within the past 3 months, we've seen all of these things take place in a very horrific way for a population, which then speaks to how trauma is contiguous. It is something that hasn't broken, and it's something that people cannot tend to get away from, because what is created the trauma is a condition of their genotype and phenotype, which leads to the assault. And so we find people trying to actually modify, correct the things that that they think are incorrect because of the larger population. For example, we have the issue of bad hair within the black community. Well, that's a psychological challenging phenomenon, because for a European American woman, bad hair day is based on the atmosphere not allowing her to style it like she wants to. In the context of people of African ancestry, bad hair is how it comes out of the scalp. And so it's bad by its nature because of, again, the ideology of a population that has been dominant has created this traumatizing experience of self, of essence of being. And so that is a disruption to how one functions. And it has to be, of course, examined and worked with in a very distinct way. So we cannot simply say that trauma in one form, the economic trauma or the political trauma, but we have to look at the totality of various traumatizing experiences of the population. And so what is the diagnosis then of a person who's experienced trauma across several generations? A very serious question, because if you talk about post-traumatic stress disorder, it's based on individuals typically who have gone through either a warring experience or rape or some type of physical violence, and they're now out of it. Post means that it is done. But when it is continuous, how do you begin to really frame a treatment, and what do you really call that thing over a period of time? Is it really even persistent systemic trauma? Is it something else? And how do people begin to adapt to that particular lifestyle, and what becomes of them in that context? I mean, what is it that can be done if one has learned to deny that it exists? Is the healing possible? So we have these critical questions that we have to ask as clinicians about the work that we're trying to do. And I'm going to pass through these slides about cultural trauma, because I want to get to a really open discussion area. I'll pause here just for a moment on the smooth back discourse. Is that can Western thought really capture what it meant to be tortured, raped, dehumanized, degraded, and despiritualized? Do we have vestiges of traumatizing experiences today? And I submit to you that the language that we use to discuss ourselves is also a part of this traumatizing experience. But this idea of the smooth back and the rough back, and so those who tended to resist the enslavement experience end up having rough backs, and so they were sold less at a lower price during enslavement because they were troublemakers. But sometimes they may not be troublemakers. They may be trying to put things into a proper perspective. And I want to submit to you that some of the work that we're doing here is shifting perspective to create a healing space for a population to have another level of wholeness and normalcy that has not been experienced, right? So we understand that when one has experienced trauma, emotions come into play. And so we know that emotions are part of the entire process that seem to contribute to other various forms of health. And so we know that within our populations we have high occurrence of diabetes, coronary heart disease, and other things. And for example, coronary heart disease is implicated in the process of stress, which deals with the fight or flight mechanism, which leads to increased cortisol within the bloodstream. Cortisol can cause plaque to build up in the bloodstream, which can cause blockage, which can then lead to coronary heart disease. So we can see then that a major contributor to the lifestyle or the death of a population may not be what we call physical health, but it could be the psychological experience of dealing with the traumatizing phenomena of living in a space where they perpetually dehumanize and or devalue. What is the visceral response that blacks may have had to make America great again, right? That's a visceral response to that. That over a period of time of seeing that can contribute to other forms of ill health. We have to be clear about the work that we're doing there and what is being traumatized. What's being traumatized is the essence of being, not necessarily a physical phenomenon that is there. And so I wanted to just simply encourage us to think about the work that we do and think about this particular model that suggests that when we have interventions with people of African ancestry, that we understand that there is the experience of the enslavement process, that there's racism that's also there. There is a normative structure or way of being that has been able to sustain itself at some level. And then there's a European normative structure that seems to impact upon that particular entity. And so the work then must look at the transgenerational aspect of trauma, look at spiritual alignment that was mentioned earlier, strive for renormalization of how that looks, and deal with the issue of the ossification of self. We think then the outcomes of this is this idea, of course, being aligned, interpersonal renormalization, a renewed sense of who we are. And I deal with this idea of Ubuntu that I came across in South Africa, which deals with the idea of humanness, right? You be you means being into you means unifying life force. So there's this idea of the unifying life force that runs through everything, and that the power of a person is really tied to his connectivity to other people. And that's why the Zulu talk about Ubuntu, Ungamuntu, Ngabantu, which is the person to person because they are people. And so the work that we do then is about dealing with the African concept of communalism and being whole in a community that clearly embraces self. We know then that in our paradigm, the value of the collective is the most salient element of existence. The idea of the communal self-knowledge is the key to total health. The spirit is the primary source of health, healing, and holism, as mentioned previously, and healing of the spirit is the healing of the body. I think we will put a pause there because we are actually at the time for questions and answers. So I just wanted to say thank you for allowing us to be a part of this conversation. Be sure to continue to look at the work that's done by the Black Psychologists. The Journal of Black Psychology is filled with content or research that's been done around some of these same topics, and so we can begin to advance the work to have a more holistic and culturally grounded aspect of the healing work. So thank you. Are there questions? We're ready for that.
Yes, Dr. Washington, we had a question about where can our participants find out more information about your African-centered model?
Okay, thank you. I am currently working to produce a larger volume of content about this, but there is one article that talks about Zulu healing in the Journal of Pan-African Studies that was a cursory discourse about the foundation of this work, and it can be found in the Journal of Pan-African Studies in 2010.
Okay, great. So we are out of time, but we will have office hours on February the 9th from 10 to 3 p.m. And that information will be available on the slide here as well as in the TA Telegram, the Technical Assistance Telegram. And we thank you all so much. To our co-facilitators, thank you so much for sharing your knowledge and expertise with our community. And I'm sure that all of this information is useful in more effectively serving African American children, youth, and families. Thank you, and happy African American History Month. See you at the next session.